This is an audio-visual screencast presentation for the Non-Medical Prescribers course level 7. The patient this case study will focus on is a 53-year-old male who presented to his GP's practice with a 3-week history of central and right-sided lower back pain. Onset was after a heavy weekend of manual work and reported no trauma. The gentleman did report a previous history of episodic lower back pain, however reported this incurred infrequently and had always settled with physiotherapy input within a fortnight. The patient reported no neurological symptoms, and screening questions were used with the aim to rule out sinister or masquerading pathology as per NICE guidelines. This included screening questions aiming to rule out Cordero-Quina syndrome, infection, inflammatory disease, visceral pathology, and cancer. The patient reported no drug allergies, was medically fit and well, and was taking no other ongoing medication. Objectively, the patient was assessed face-to-face and reported pain localized to the lumbar spine, which increased with range of movement testing, and a mild restriction of range was noted. Tenderness was present upon palpation of L3, 4, and 5 vertebrae and right paraspinal muscle groups. No neurological symptoms or deficits were present upon straight leg raise test. Myotomes, dermatomes, and tendon reflexes were normal. His hip and sacroiliac joint presented to be unremarkable upon testing. Diagnosing acute lower back pain is often considered a ruling out process, and as per clinical knowledge summaries by NICE, masquerading and sinister pathology should be ruled out prior to consideration of a mechanical diagnosis, with consideration of radicular features. This can be seen to have done in the patient's assessment. This diagnostic framework is further supported by the National Lower Back Pain and Radicular Pain Pathway, which stresses the importance of history taking and ruling out pathology to ensure accurate diagnosis. It also discusses the use of the Startback screening tool, a 9-point screening tool developed to promote stratified healthcare. This was undertaken with a presenting patient. A total score of 6 and subscore of 3 were established, indicating a moderate risk of chronicity. The use of the Startback screening tool is identified as an appropriate tool for identifying high-risk patients in primary care, according to Hill 2010. However, there is clinical debate around the use of the tool, as highlighted by Kendall et al., who reported the tool had a poor predictive and discriminative ability for future pain. Available local policy by the Derbyshire Trust also supports this assessment, and once established as non-specific or mechanical in the back pain presentation, we should look at treatment according to Oliveira's review of managing acute lower back pain. In primary care, it suggests 3 approaches. Firstly, appropriate tailored analgesia, with this presentation will cover. 2, advice and education on back pain management. And finally, a consideration of physiotherapy referral, which was offered to this patient but declined as he was already under a private practitioner. This policy also states there's no requirement of any benefit of any form of imaging, such as X-ray or MRI at this stage for the acute lower back pain. This is further supported by Bernstein and Ryo 2017 and 18. When prescribing medications with patients, local and national pathways should be considered, and any prescribing decision should be deemed patient-specific and tailored, using these policies as guidelines alongside a patient-centered approach according to WHO 2009. NICE guidelines discuss the pharmacological management of lower back pain. As a first-line measure, a non-steroidal anti-inflammatory is made at the lowest dose for the shortest period of time. This suggestion of using an NSAID for acute lower back pain is further supported by local policy. Both guidelines refer to monitoring risk factors for specific patient groups when using NSAIDs. These were discussed with the patient in the case study prior to consideration of the prescription and will be discussed later. Hierarchy of evidence was considered. A Cochrane systematic review of the use of NSAIDs in acute lower back pain by Vandegaard 2020 established that there is high quality evidence to suggest that NSAIDs are slightly more effective in short-term improvement of disability and pain than a placebo. A limitation of this research, however, was that almost half the studies included were industry funded, leaving the potential for researcher bias to occur with questions around vested interest. Patient allergies were considered. The patient reported to have taken ibuprofen on previous multiple occasions with no adverse events or allergic reactions. After consideration of local policy, national frameworks, reviews of evidence and patient-specific factors, including the fact that he is self-employed and currently struggling to work, the suggestion was made for him to use the NSAID ibuprofen, one 200 mg tablet 3 times a day. The advice was given that if this was not providing adequate relief and he wasn't experiencing any adverse effects, he could increase this to 2 200 mg tablets 3 times a day. Consideration of a proton pump inhibitor was taken. However, after a review of NICE clinical knowledge summaries, a a patient with a low GI risk when prescribing a short-term course of a non-selective NSAID, a PPI is not required in the first instance. Upon the decision-making of whether to use a prescription or not, it was agreed with the patient for him to purchase the ibuprofen over the counter. He was happy with this approach financially and practically. Overall, this was a shared decision-making process between myself and the patient, taking into account concordance and the Royal Pharmaceutical Society guidelines, the prescribing framework. Alcohol use was discussed with the patient. The NIH discusses the risk of excess alcohol use and increased risk of gastrointestinal problems to patients using NSAIDs. The patient was made aware of this, however, we informed ourselves he rarely drank alcohol. A decision was made to review this patient's care in 3 weeks' time via a telephone consultation. He was informed to take the ibuprofen with food and to contact the GP's practice if he noticed any adverse events. However, he was informed the drug was considered relatively safe in his situation. Looking at the pharmacodynamics of ibuprofen. Ibuprofen is a non-selective, non-steroidal anti-inflammatory, which works by blocking cyclooxygenase 1 and cyclooxygenase 2 enzymes, which in turn decreases prostaglandin synthesis. It is a prostaglandin antagonist and it is non-selective, therefore acts on both COX-1 and COX-2. The blocking of the enzyme, specifically COX-2, leads to a decrease in prostaglandin H2 and ultimately E2 and F2, meaning ibuprofen has the effect of being an antipyrexic, anti-inflammatory, and decreased pain. Prostaglandin production is an essential part of the inflammatory response, so in turn decreases inflammation, which is the desired response for our patient alongside pain. However, as ibuprofen is non-selective, we have to consider what other effects may occur when blocking these both COX-1 and COX-2. Inhibiting COX-1 can have gastrointestinal effects, which may require monitoring or consideration with individual groups. COX-1 converts arachidonic acid into prostaglandin H2, which then forms prostaglandin E2 and I2. These prostaglandins help maintain stomach acid production and maintain gastric blood flow. Therefore, if COX-1 enzyme is blocked, acid production can increase, giving the potential for GI side effects such as ulcers, hemorrhages, or dyspepsia, particularly in higher risk groups. Gastrointestinal risk factors and side effects were discussed with this patient prior to commencing treatment, who reported no active GI problems or history of GI problems. Prostaglandins also have a role in bronchodilation. If prostaglandin synthesis is inhibited, this can lead to bronchospasm in patients with asthma or other susceptible groups. This was not relevant for the considered patient, however. In the kidney, COX-1 also converts arachidonic acid into prostaglandins. These prostaglandins help maintain renal blood flow, glomerular filtration, and therefore ibuprofen, by blocking COX-1, can increase risk of kidney injury. NSAIDs are used with caution in patients with renal failure according to the BNF. The patient reported no history of kidney problems, and the clinical decision was made at the age of 53 for a likely short-term course of ibuprofen. There was no requirement for a blood test to assess eGFR. This has been supported by Modig et al. 2018. In platelets, prostaglandin H2 is converted to thromboxane A2, which is a chemical which promotes platelet aggregation to assist clotting, which results in the drug also having an anticoagulative effect and increases the risk of bleeding. The patient in clinic reports no clotting or bleeding concerns. Cardiovascular considerations were considered. Varga et al. 2017 reported the associated risk of using a non-steroidal anti-inflammatory on the cardiovascular system, noting the risk of heart failure, hypertension, and increased risk of thrombotic events. The patient reported no cardiovascular history or risk factors, and these events were deemed to be considered a very low risk for a short-term course of treatment for a healthy individual, according to Fospol et al. 2010. These events were reported to be more commonly seen in the use of diclofenac than other NSAIDs. At the age of 53, the gentleman in question is clearly not in the elderly category, where the use of NSAIDs should be used with caution. The patient was taking no other medication at this moment in time, so drug interactions were not required to be considered. Regarding the pharmacokinetics of ibuprofen, the absorption as a drug for this patient was given orally and is a drug that is rapidly absorbed after ingestion through in the intestine. 80% of the oral dose is absorbed through the GI tract. Distribution: ibuprofen is extensively plasma bound, approximately 99% at therapeutic levels. The volume of distribution is 0.1 to 0.2 litres a kilogram. peak plasma concentrations occur within 1 to 2 hours. Metabolism. Ibuprofen is metabolized predominantly in the liver, but may occur in the gut as well. Ibuprofen is completely metabolized with little to no unchanged drug in urine. It is metabolized rapidly by the cytochrome P450 enzyme family. Elimination. The excretion of the ibuprofen is complete and rapid. The primary route of elimination is oxidative metabolism to inactive metabolites. Ibuprofen's elimination half-life is 1 to 2 hours. Prescribing legislation has been considered throughout the consultation. The Chartered Society of Physiotherapists provide guidance for physiotherapists from an undergraduate level to independent prescribers. All physiotherapists are prescribed to have some medicinal advice in line with current NICE guidelines and frameworks, particularly in their scope of practice. The use of ibuprofen fits these NICE guidelines and CSP's guidelines legally. Ibuprofen is also on the general sales list, meaning the gentleman can purchase the ibuprofen from a local shop. He may be limited on pack size, but stated this was not an issue as he likely required short-term use. The CSP as a union provides further guidelines on liability, stating the HCPC registrants are required to hold adequate indemnity to practice. In my case, as an individual, for somebody who works for a hospital's trust, this is why I'm supported legally, and the CSP is my registered union. Independent prescribing is an accepted part of physiotherapy practice with individuals who hold additional HCPC annotation. For myself, this is something I'll be undertaking upon completion of the course. As a member of the CSP, I'm provided with public liability insurance, which allows me to work within my scope of practice. Once qualified as an independent prescriber, I must only prescribe within my scope of practice, and I will be solely responsible for my decisions. The HCPC provides further information on the legal frameworks for independent prescribers in order to meet their standards of practice alongside the NHS England framework. Biomedical ethics were considered throughout the prescribing process as per Beauchamp and Childress's four-principle framework. The patient's respect for autonomy was considered, and professional information was provided to the patient to make informed decisions on the discussed topic. The benefit to risk ratio was considered, taking into account any potential or likely harm to the patient and cost. These were both deemed to be on a low level compared to the moderate benefit potentially achieved. Consent was clearly given for the assessment and suggested treatment. The patient was active in his decision making, and verbal consent was given. The patient did not fit any criteria for mental capacity assessment, and clearly to myself and my practice educator could make competent independent decisions for him to engage in the prescribing process. Throughout the assessment and shared decision-making process, the Royal Pharmaceutical Guidelines were implemented regarding the principles of the competency framework. Parts 1 to 6 have been discussed heavily in the assessment so far. Parts 7 to 10 refer to prescribing governance, which were also taken into account. Part 7 prescribes safely. The use of NSAIDs for a healthy individual with acute lower back pain is deemed to be considered common practice as per local and national pathways discussed, and is considered within the scope of an MSK practitioner. Common adverse reactions were considered unlikely with the patient and discussed in the assessment. Part 8 refers to prescribing professionally. Professional competencies were ensured throughout the process as per HCPC guidelines, as discussed in the ethics considerations. Part 9 is improving prescribing processes. After the consultation, a 20-minute slot was scheduled to review my assessment and decision-making with my practice educator who oversaw the assessment. She deemed the process safe and effective treatment, and a written reflection by myself was performed using the Gibbs model. Part 10, prescribing part of a team. The assessment was a joint assessment with my educator, and further knowledge was underpinned and made available by spending other time with clinicians upon my prescribing journey. Continuous professional development is noted to be of high importance to any physiotherapist, particularly those after undertaking independent prescribers course. In my current role, there are multiple opportunities to continue with this. A bi-monthly county-wide MSK prescribers forum will be undertaken, something I've already started whilst undertaking the course. I am also undergoing the first contact practitioner portfolio, as set out by Health Education England Roadmap. This process to gain accreditation involves regular supervised practice, COTS, reflective tools, and ongoing review of evidence in MSK and prescribing practices over the next year. Time has been given to myself by the Trust to accommodate and prioritise this. And finally, my references.